Good evening, everyone. Welcome to this month's academic session from Spice Route, Karnataka. It is my great privilege to introduce Dr. Mahendra, Professor and Head of Department of Neurology, MS Ramaya Medical College and Hospital. Sir has finished his MBBS from Bangalore Medical College and MD General Medicine from JNMC Belgaum. He has finished his DM in Neurology from TNMC Mumbai. He was the topper of university exam in DM Neurology. And Sir has published many articles in various publications. Thank you very much, sir, for coming and welcome to Spice Route, Karnataka.
My pleasure.
Okay.
My pleasure.
Thank you, sir. It is my great pleasure to introduce Dr. Soumya Vivek, consultant and HOD Trustwell Hospital. She's a HOD of Department of Family Medicine in Trustwell Hospital. Thank you very much, ma'am, for coming and welcome to Spice Route, Karnataka.
Thank you so much, Nishan, for this opportunity. So,
yes, ma'am. I would like to thank Dr. Gunjan Jha from National Spice Route team as well for helping us organize this session. And I would like to welcome all the PGs to use this platform for learning. It was an interactive session last time, so I hope it will be an interactive session this time as well. So if you have any doubt, please put it in the chat box and we'll clear them at the end of the presentation. And please do unmute yourself after the session. So during the session, please keep the mic muted. Today's session will be presented by Dr. Mashuda Banu, second year resident from District Hospital Chitradurga, who will be presenting a CNS case. Over to you, Dr. Mashuda.
Thank you for this giving this platform. I will start now.
Mashuda, can you be a little louder?
Okay. Good evening, sir and ma'am. Respected sir. All.
Good evening.
Good evening, dear.
It is a privilege of me to present here before you all. Okay. Let's start, sir. I will be presenting a CNS case, sir.
Yeah, start, Mashuda.
Please start. Please start.
Patient Mrs. XYZ, 85-year-old female, hailing from Chitradurga, homemaker with 5th standard education and right-handedness, informant doctor, reliable. Date of admission on 9/12/2024. Presented with chief complaint of weakness of right upper limb and lower limb since 5 days, decreased speech and slurred speech since 5 days, deviation of angle of mouth to left side since 5 days. Sir, go ahead. No?
Please go ahead. Once the issue is over, we'll discuss.
Okay, sir. Okay, sir. History of presenting illness. Patient was apparently normal and performing her routine activities until 5 days back. Patient was all right when went to sleep at 11 p.m., following which she felt weakness at around 6 a.m. while getting up from bed. She noticed the weakness in right upper limb and lower limb such that she couldn't get up from bed. Later around 7 a.m., with support of daughter, she walked to the washroom and she was having difficulty in gripping her slippers too. She also having difficulties to hold a glass of water, combing her hair. However, she was able to raise her arm. Patient was further brought to ER of District Hospital at around 7:30 a.m., during which her weakness progressed to such that she was completely unable to move the upper limb and lower limb.
Just a small clarification, Mashuda.
Yes,
did she call her daughter? Could she speak?
No, ma'am. She later on, it is in the history I am presenting, ma'am. She didn't call it. She couldn't get up from the bed. That time, after her daughter came around 7 a.m., ma'am.
Okay, daughter noticed her and then came to her. Okay.
Yes, ma'am. She didn't talk that time, ma'am. Patient has difficulty in speech as slurring, which was sudden in onset and at the time of weakness, and it was gradually progressive. Even though she was able to understand and obey commands, while attempting to speak, it was slurred, and the speech was not clear to the attenders. Word output is also decreased. In the hospital, the slurring of speech is in slowly resolving state, and now even word output is also increased.
This is the history, no?
Yes, sir. Pa-
Yeah. Complete.
Patient complains of deviation of angle of mouth to left side while speaking and showing teeth since 5 days. It was sudden in onset on the day of weakness, and it was not associated with cooling of saliva. She has no difficulty in chewing food or closing her eyes. Now, negative
Okay.
history.
Now, negative history. Before that, now,
Yes,
how do you analyze the symptoms? Can you analyze the symptom each by each?
yes, sir.
One, yeah.
She has upper limb, both right-sided upper limb and lower limb weakness, and it was started around early morning, sir, and it was sudden onset,
Mm.
and it was
How do you know it is started around 6 a.m.?
that
Why is that important?
early morning
Why is
weakness.
that?
Timing of the weakness is important, sir, as waking up from sleep.
Correct.
That early morning stroke will give clue to the diagnosis, what type of stroke it like that.
See,
Yes, sir.
correct. That is one thing. But more important than that,
Yes,
for treatment aspect, you have to note down exactly when is the patient was last seen normal. Okay.
sir.
So this is called as this is called wake up stroke.
Okay, sir.
Correct. When patient woke up, she noticed the weakness.
Yes, sir.
So we don't know when it has exactly happened.
Mm.
In these conditions, it is when it comes to treatment, we'll discuss later. Like when it comes to treatment, whether patient to be thrombolized or not.
Yes, sir.
Treatment wake up stroke, we always consider last seen normal. So in this case, last seen normal was when she went to bed at
It
11
was 11
p.m.
p.m. Yes, sir.
Okay, so it might have happened anytime during the sleep. We don't know. She was
Yes.
not woken up in between. So she noticed when she woke up at 6 a.m. So you cannot take that as a time when it has happened.
Okay.
So we will discuss that. How will we confirm it and how to differentiate all those things. Just remember that is very important. Timing of onset as well as wake up stroke. Okay. So what do you think patient has now?
Patient has weakness. With that, patient had slurring of speech, and patient have deviation of angle of mouth, sir. 3 major.
Can you describe more about the speech?
Speech.
Weakness is okay. Weakness is explained.
Yes, sir. Speech. She was able
Speech,
to.
can you?
She was able to understand what they are telling, but the patient is attenders was not able to understand. It was not clear to the bystanders her speech, sir, and word
Yeah,
out.
you should mention patient as. You should mention as difficulty in speaking. However, patient could understand what patient relatives were speaking with decreased word output. So what do you think it is?
It is
First, describe the weakness. What do you think the weakness is due to?
sir, weakness is due to which motor, sir?
What do you think?
Motor.
What do you think the weakness is due to? Is it a stroke?
Yes, sir. Stroke.
Why do you think it's a stroke? Why do you think it's a stroke?
That's speech only, sir, is asking, or whole, sir, is asking?
Whole, everything, all the symptoms.
Sir, that one hemiparesis with that one-sided weakness with the slurring of speech and deviation of angle of mouth. This going through stroke-like features only, sir.
Correct.
Weakness.
So where do you want to localize?
I think it is an internal capsule only, sir.
Why do you think it's internal capsule? Why not coronary data? Why not higher than above? Why not it's a big stroke affecting involving frontal lobe, temporal lobe?
The cortex or subcortical features like consciousness, seizures, it is not affected. Seizures are not
See,
there.
whenever you present a stroke case, no, you
Yes, sir.
can measure patient has a right side hemiparesis with speech difficulty,
Yes, sir.
okay, speech involvement and human facial weakness.
Yes,
You
sir.
have to say, I would like to localize to the left MCA territory.
Yes,
You should
sir.
say it is in the territory. It was involving the territory,
Okay,
you know,
sir.
like left MCA territory, rather than pinpointing to internal capsule.
Okay, sir.
Understood, no?
Yes,
Very
sir.
rarely we see involving only internal capsule.
Which arterial
In
factor we have to tell, sir.
Yeah, better to say it is involving the left MCA territory.
Okay, sir. Okay.
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 Now tell me how will you differentiate clinically when do you suspect patient is having only MCA territory? When do you suspect patient is having ACA territory? In fact,
If limb and phase involvement, sir.
see, that's what. Which limb? How do you say? See, basically, patient having hemiparesis, upper limb predominantly more affected than the lower limb or
Right.
equally affected with speech involvement
Yes,
goes
sir.
more in favor of MCA.
Territory.
That is dominant. That is left MCA, dominant lobe. Okay.
Yes, sir.
If leg is more affected than the hand, okay,
Yes.
leg is more affected than the hand. In the hand also, they can move their fingers, but not able to lift the hand above the shoulder.
Yes,
That is,
sir.
proximal aspect of the arm is more affected than the distal aspect. Then,
Proximity.
then ACA is more affected than the MCA. Okay. In MCA stroke, it's predominantly hand finger movements are more affected than the proximal weakness. Whereas in ACA, proximal hand is more affected than the distal hand. And
Yes.
leg is more affected than the upper limb. Understood, no?
Yes, sir. Yes, sir.
Okay. And what type of language involvement will be seen in MCA? In MCA also we can think whether anterior division or posterior division. It should be need not think twice, but at least language is affected. Then you can say, okay, which hemisphere is language areas involved affected?
Which area is involved?
Broadman's area. That is
Okay. What is it called? What is Broca's area?
Broca's area.
What is Broca's aphasia?
Broca's aphasia means area in the frontal third, inferior frontal convolution third area.
Okay.
That is affected.
Inferior frontal gyrus involvement. What are the clinical features of Broca's aphasia? Does this patient fits into Broca's aphasia?
Yes.
We are still in historical aspect.
Yes,
Yeah.
yes. Fluency and rhythm of speech will be affected in Broca's aphasia, sir.
Okay.
And grammar or syntax may also affected because it is.
See, all those things are. Yeah, please continue.
Broca's area where maintenance of grammar and syntax is done, sir. Then purely articulation is affected if Broca's affected.
See, you have written word output is reduced, no?
Yeah.
How do you say? What do you mean? What do you mean by normal word output? You don't know. No, it's okay. See, basically, what happens whenever patient speaks in sentences?
Yes, sir.
You know, at least sentence should contain at least 4 to 6 words.
Yes, sir.
See, this word output usually in an English speaking population,
Hmm.
they will say they have to speak at least 100 to 150 words per minute. You know, that we cannot sit and count the word thing. So what we usually say is patient should speak fluently and should make sentences, converse in sentences. That means patient is having a normal word output. However, in patients with a decreased word output, like in Broca's aphasia, they will speak in few words, like, you know, we call it as telegraphic speech. They like instead of asking, I need water to drink, I'm thirsty, they'll just say water, and that too not very clear. Understood, no?
Okay, sir.
Yeah, that is how they present.
Okay.
And here, how will you differentiate a dysarthria from aphasia or dysphasia?
Dysarthria means difficulty in articulation, sir.
Okay.
And then
Why not this is difficult in articulation? Why do you say it is aphasia? And why is it important?
articulation mainly involved by the lower cranial nerves, sir. Muscles.
Correct. Articulation is predominantly cranial nerves.
Cranial nerves, sir. And
And how
speech
do you differentiate clinically, ma?
clinically,
Mashuda, what words do you ask the patient to repeat to differentiate? That's what sir is asking. Bedside, to understand articulation issues.
we will tell rhyming words to repeat the words, whichever we are telling the patient to repeat that words again.
That is repetition. One repetition will be preserved in dysarthria, whereas it can be affected in speech, I mean language dysfunction.
Yes, sir.
And another important thing is reading and writing. You know, even if patient is severe anarthria, can read and can write.
Yes, sir.
Whereas aphasia cannot write because it's a language. Did you understand?
Yes, sir. Yes, sir. Language will be affected in aphasia, sir.
Yeah, I mean reading and writing will be affected
Affected.
because it's a language problem. Aphasia
Yes.
is a language problem.
Okay, sir.
Whereas dysarthria is only articulation problem.
Articulation problem.
Good. And what is crossed aphasia?
Post aphasia.
Okay. See, what happens
Other
usually
physics can
aphasia.
also answer.
Yeah, please. Anyone else? See, basically aphasia, when we say it is in a dominant hemisphere is involved, you know, 99% of the time it's left hemisphere. In a left-handed in a right-handed individual, if right-sided hemispheric stroke causes language dysfunction, it's called crossed aphasia. Understood?
Yes, sir.
Dr. Lijo has answered non-dominant aphasia. Is crossed aphasia.
Correct. Yeah, it's in a right-handed individual, not in a left-handed individual. In a right-handed individual, if right-sided hemisphere stroke causes aphasia, it's called crossed aphasia. It's very rare condition, seen less than 1%. Okay, ma'am, you can ask, ma'am. You can continue.
Dysarthria bedside can be asked simple, letters to be repeated so that we know that it is dysarthria. Do you have any clue? We know that it is orbicular resource issues, or it can be palatal
Correct.
palsy. What do you ask bedside? No, see, many a times we don't have. We are all working in, many of you, in resource limited settings. If you have a privilege of having a CT scan, it is such a great thing, right? So all the exercise goes into assessing the patient clinically. Correct. So because you are from a district.
So what words you usually say, ma'am?
How do you assess bedside?
Like repeat some rhyming words we used to tell, sir, before doing repetition. or we will ask his details only, patient details only, like name and all.
Any other PG?
No, ma'am, madam. Oh, anyone else? Somebody has mentioned as labials. See, basically, what we look into is,
Yes.
Papa, Baba,
Pataka.
Ma,
Yeah.
Ta,
We
ta,
usually
ta,
say
na.
pataka.
Yeah,
Something
simple
pataka.
word, pataka. That will test both labials, linguals, and guttural. Pa
Yes.
for labial, ta for lingual, and kha for guttural sounds. So pataka will tell us whether which is affected. So in detail, you can go for Papa, Baba, Ma, Ta, ta, da, da, na, and Ka, Kha, Gha, Ga, Na. Okay.
Okay.
Yes.
Okay.
We'll go ahead, sir. Next slide.
Yes, ma'am.
Mahendra ji.
Please. Yes, ma'am. Please. Continue.
Okay. No history of headache, projectile vomiting, altered sensorium. No history of head or spine trauma. No history of loss of consciousness, transient loss of vision. No history of behavioral abnormalities. No history of aura, seizures, or post-ictal confusion. No history of involuntary movements or urinary or fecal incontinence. No history of loss of sensation of any part of body. No history of double vision, tinnitus, or vertigo. No history of difficulty in swallowing, nasal regurgitation. No history of hoarseness of voice.
If patient complains of loss of sensation of one half of the body, where do you localize? And sudden onset, stroke wise, which part of the brain will be affected?
Lateral spinal column.
One half of the body. One half of the
Hemisensory
body.
loss. Oh.
Hemisensory loss. Where do you localize? Anybody else?
Internal capsule.
Anyone else want to type? Like right half of the face and right half of the body. Yeah, somebody has typed it as
Yeah,
thalamus. Correct.
thalamus. Yeah.
Thalamus. Huh? See, what you're talking about lateral thalamus it is actually, it goes through the thalamus, no?
Mm.
Thalamus is one thing where it will get hemisensory loss.
Mm.
Okay, where do you get crossed sensory loss? That is one half of the face and opposite half of the body. Anybody? Which type of stroke do you get crossed anesthesia sensory loss? That is, for example, right side of the body, brainstem exactly, but where exactly in brainstem?
Brainstem is big one, no?
Big one.
Somebody has
Yeah,
said
it's lateral
medulla.
medulla. Yeah, lateral medullary infarcts. Okay, where one of the half of the face and opposite of the body will be affected. Okay. Now, because we are here, I want to just ask one question. What is crossed hemiparesis? Can you tell, Dr. Masuda?
Yes,
What
sir.
is crossed hemiparesis?
Lesion one side and this weakness in one side.
Does
Yes.
this patient has crossed hemiparesis?
No, sir.
No, it's a classical hemiparesis. Okay. So now tell me, what is crossed hemiparesis?
Lesion in one side and
Moshu, the direct loop. One side weakness, one side palsy. What palsy?
facial.
Correct. Yes. See, that is one half the face, opposite side, or even any cranial nerve involvement. One, for example, if there is a left, here this patient has a right side facial weakness and right side weakness.
Yes, sir.
In crossed hemiparesis, there will be left-sided cranial nerve involvement. Whether it can be left-sided sixth nerve, left-sided fourth nerve, left-sided seventh nerve, and opposite side hemiparesis. That is called crossed hemiparesis. That will tell us the localization to, that will take us the localization to brainstem, not in the hemisphere. Understood?
Yes.
Okay, please continue.
Past history. No history of similar complaints in the past. No known comorbidities. Patient diagnosed as diabetic, hypertensive, dyslipidemic, hyperthyroidism after hospital admission and started medication for the same. Diabetes started with metformin 500 mg VD, and hypertension started with tab amlong 5 mg 10, and dyslipidemia started with tab atorvastatin 5 mg, and hyperthyroidism started with tab thyronome 50 microgram.
Hyperthyroidism or hypothyroidism?
Yeah.
Thyroidism.
Hypo.
Hypothyroidism. Sir.
Yeah, okay.
I don't know.
Thyroid.
Okay.
And this, just a comment, please go to the previous slide.
Yes,
So
sir.
after this patient has come, you have detected her to be diabetic, hypertensive, dyslipidemic,
Diagnosed.
hypothyroid, right?
Yes.
This is the usual scenario. Dr. Mahendra ji can also comment, because most of them who come will be newly diagnosed, undetected hypertensive, diabetics, and who succumb to this. Especially in rural areas, I think 40% of the patient, they succumb to some sort of disability because of lack of identification. That is where primary care physicians have an important role to screen for all
Absolutely.
these comorbidities. Okay. Otherwise, you can say that, and you take this opportunity to educate the family members also, for regular checkups, at least screening checkups. Okay.
Family history. No history of stroke, young stroke or myocardial infarction in family. Personal history. Consume a mixed diet pattern, normal appetite, adequate sleep, regular bowel and bladder habits. Patient is catheterized and using adult diaper after admission. History of alcohol consumption, mainly as homemade wine from 20 years of age. Last drink was 10 months back. No history of smoking and tobacco use. Summary, sir.
Yeah, please go ahead. Sir is listening.
Okay. Elderly woman with diabetic hypertension and dyslipidemia and hypothyroidism presented with sudden onset weakness, equal weakness of right upper limb and lower limb, associated with slurring of speech and deviation of angle of mouth to left side, with no sensory deficit. History suggestive of neurological deficit, probably due to thrombotic.
Sorry, I was not able to join. So there's some disconnection.
Okay, so she just summarized. Read through again, doctor.
Okay.
Okay, sir. Elderly woman with diabetic hypertension, dyslipidemia, and hypothyroidism presented with sudden onset equal weakness of right upper limb and lower limb, associated with slurring of speech and deviation of angle of mouth to left side, with no sensory deficit, and history suggestive of neurological deficit, probably due to thrombotic ischemic stroke in left MCA territories.
Good. Why do you say thrombotic stroke? Specifically, you mentioned thrombotic.
Yes, sir. It is like early morning stroke with the maximum of weakness as a progression.
But it is not like maximum at the presentation. No, as per your history, see progress over few hours. It is not maximum at onset. But you are mentioning it as thrombotic. It is not. You are conflicting your own history. See, basically, how will you differentiate ischemic versus hemorrhagic stroke?
Hemorrhagic means alert active hypertensive patient with symptoms of raised ICT will be there, sir.
Alert active?
With respect to onset, the way it comes in,
Yeah.
you have to explain a bit more.
Okay.
Yeah, correct.
Alert active
Patient.
Awake patient with
alert active patient. Some
during some
precipitation
activity
suddenly become weakness with worsening of sensorium. over few hours, no?
Okay. Yes, sir.
And maximum weakness at onset associated with loss of consciousness and sometimes seizures also.
Yes, sir.
Okay.
Yes, sir.
And yeah, if we are all talking about big hemorrhages, not a small tiny hemorrhage. Sometimes it is very difficult to differentiate.
Okay.
Now, how will you differentiate the thrombotic from embolic?
Embolic, maximum at the weakness onset, completely.
Here, maximum weakness at the onset,
With any
sudden onset,
any history
and
of most probably
and probably history of some cardiac illness associated cardiac illness or rhythm abnormalities.
Yes.
Okay.
Yes, sir.
Whereas thrombotic is, as you know, progresses for a few hours,
Yes, sir.
and history of TIAs in the past, you know. And why is it important, ma?
What, sir? TIS.
Whether it
Whether to
is
differentiate whether thrombotic or embolic.
embolic or even hemorrhagic for that matter.
Yeah.
For the management of the patient, sir.
See, yeah, management of the patient, absolutely. See, most important thing is to look, whenever stroke happens, what we see is, see, one is treatment aspect, second one is to prevent another attack. That is the most important thing.
Further progression of stroke.
Yeah, evaluation, whether it is, we look for what is the cause of a stroke. No, is there any carotid artery stenosis? Is there any dissection? Is there any large MCA, M1 occlusion? Or is it atrial fibrillation? You know, or is there any clot sitting in the left ventricle? See, basically, management also differs, and you can prevent another attack.
Further,
yeah, is it emboli or is it a thrombotic? If it's a thrombotic and the lacunar stroke, only antiplatelet is sufficient along with control of the risk, comorbidities. Okay.
And also, if you are sitting in your primary health center or CHC, you have to decide whether you can treat the patient in your setting or stabilize, give certain preliminary medications, and try to shift to a stroke-ready hospital. This is very important because there's what is called as a golden hour in stroke. Yeah? Like how you have for myocardial infarction, the door to needle time even in stroke is much lesser. So you have to use your clinical judgment and see if you can treat or not your patients. And most of them would see you first, right?
Yes.
Okay, thank you.
So what is the only test which is required to thrombolize? Most important test. Have you thrombolized anytime?
No,
have you witnessed thrombolysis at least?
No. Here
no, you all start in district hospital.
Yes, yes. Akila P has answered CT brain.
Yeah, CT brain, perfect. CT
So
head. If CT head rule out hemorrhage, if patient has a definite stroke, no few blood tests like ruling out thrombocytopenia and other things, please thrombolize.
Sir, and also we don't wait many a times for receiving the blood test, no sir. Once you find that the CT brain doesn't show any hemorrhage.
CT brain is normal, except for if patient is on warfarin and anticoagulants. Otherwise, sometimes we just want to do on platelet count, madam. We don't know whether they will have thrombocytopenia or not for legal issues.
Yes, and also we look into the BP aspect, sir, just before thrombolysis. Just when sometimes many patients have BP, very high BP, 170, 180. Right? Yes, sir, please go ahead. Yeah.
See, BP should be less than 180 by 105 for thrombolysis. Please, madam, please continue.
Okay.
As primary care physicians, you also have to simultaneously stabilize BP. Like whenever there is a code blue, right, you alert the code blue team. So when you see a stroke patient inside your ER, you simultaneously have to alert your stroke team. Okay. you have to form a stroke team there, which involves a neurologist, a radiologist, your technicians in your radiology room, very important. And you as a ER clinician, try to stabilize the BP, take the bloods and try to, procure whatever the necessary medications required to initially stabilize. This is called as a stroke activation team, right? You need to activate your stroke. So all of you, wherever you are, you have to form such teams so that you know how you operate at your various hospital levels, wherever you are, and how much can you treat, and how much, when, and which hospital to refer. Okay. We also involve certain neurologists. Correct me if I'm wrong, sir. If you have a CT scan center and if you just do a CT brain and if there is no hemorrhage, we take the help of neurologists through teleconsultations, and with their guidance, many of them have thrombolysis.
Correct.
Yeah.
Correct. Absolutely, ma'am. Yeah, yeah.
So
And
thrombolysis does not require only a neurologist to do. Please understand.
correct.
In
See, that is
Indian law,
all our
even an
intention is,
MBBS, yes,
yeah,
doctor can do it. In fact, in
correct.
many centers, I have heard, in some centers, rural areas in India, where neurologists give a teleconsultation, and sometimes even Ayurvedic doctors, they discuss with the neurologist and they go ahead with thrombolysis. Legally, as
Yes,
per
ma'am.
MCA, it is not permitted. But considering the best interest in saving the patient life, they have done all these exercises.
See, 10 years back, in fact, we all trained all our district hospital doctors, what about emergency management of the stroke. Main intention is to thrombolyze. Once after golden hour is gone, if nothing can be done.
True, sir. And do you have an age limit for thrombolysis? Sorry
See,
for that.
basically, the thrombol is 100-year-old also. There are
Yeah.
instances we are thrombolized. I don't think we can get any older than that. See,
Yes.
basically, what they say is up to 8 years is above 8 years is a relative contraindication. It's not a contraindication. It's a relative contraindication. See exactly whether the patient was absolutely walking around before developing the stroke. Is premorbid MRS. We call it as premorbid state. If premorbid state is normal, I think you should go ahead and thrombolize even if a patient is above 80. If patient is having a lot of comorbidities, CKD patients, not bedridden, then only you should think twice before thrombolizing. Nowadays, in fact, we are doing all mechanical thrombectomies. We any patient coming in stroke, do a CT brain. If there is no hemorrhage, thrombolize, do CT angiogram in the same setting. If there is a large vessel occlusion, we call LVO, either in the form of M1 occlusion or M2 occlusion, then directly shift the patient to cath lab and then do a mechanical thrombectomy. In fact, Dr. Mashuda, what is NNT? It's called number needed for treatment.
69.
Do you know which procedure has the best NNT in the whole medicine? Mechanical thrombectomy for stroke.
Is the one.
For stroke. In fact, NNT
Fantastic
is 2.
results.
That means, in fact, for every 2 patients, you will see improvement in 1 patient. You don't have any medical procedure with such a best NNT. And for thrombolysis, NNT, if you treat within 1.5 or 90 minutes, NNT is almost 4. So earlier the better. Just because we have a time for golden hour is 4.5 hours, you should not wait till 4.5 hours. Earlier the better the outcome. Okay.
And I would request all residents, please get connected to your nearest neuro teams wherever you are. Interact with them. Try to witness a stroke. See how they manage. Then learning theory, you should really work with neurologists in ER. How beautifully they manage, even the ER clinicians. From the ER room till the imaging, till the patient recovers, We as PGs used to make small videos how the patient was before and how the patient improved after some injectables. But now it is an era of mechanical thrombectomy, as Sir said, and you should have a privilege of a neuro-interventional radiologist to execute all this.
Correct.
Okay.
Go ahead, Mashuba.
Please continue, ma'am.
Okay. Going to general examination. Date of examination was on 11/12/2024. Patient is conscious, cooperative, and well-oriented with time, place, and person.
These are all pre-printed thing. Patient is aphasic. How can you write patient is well-oriented with time, place, and person, all those things? Don't, have that same mentality. I'm 100% sure we have seen so many patients with FSA, they will not even talk. How will you know whether patient is
No,
oriented
correct.
time,
Way
place, and
how they
person?
are oriented on. Totally agree.
Just right, patient is conscious, looking around, obey simple commands. That's enough.
Okay,
Okay.
sir.
Yeah.
Yes, sir.
And in neurology, always write what you see. Don't follow the
Yeah.
textbooks. Okay.
Absolutely.
Okay, sir. Moderately built and nourished. Patient on supine position with IV cannula on right arm, nasogastric tube and urinary catheter in situ.
And another important thing, patient is right-sided
No
hemiplegic.
pallor, icterus cyanosis.
Dr. Mashuda,
Yes, sir.
patient
Yes,
is
sir.
right.
Yes,
Patient has weakness in the right side, right arm.
yes, sir. Yes, sir.
Always try to avoid injections and IV cannulas in a hemiplegic hand. Okay.
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 And also, you cannot even check BP in that hand. Please note. I've seen many residents, they go and try to check BP on the side of weakness.
Yeah.
Okay. No pallor, icterus cyanosis, clubbing, lymphadenopathy, edema, pedal edema. No wasting, xanthoma, acanthosis nigricans, or presence of any neurocutaneous markers. Hair grayish, skin is wrinkled, senile purpuric lesion over forearm, nail, breast, and thyroid appears to be normal. So pulse rate was 78 beats per minute, regular rhythm, normal in volume and character, no radiofemoral, radioradial delay, no vessel wall thickening. All peripheral pulsations felt equal intensities bilaterally. BP was 130/80 mmHg in left upper limb, supine position. Temperature 36.8 degrees Celsius. Respiratory rate was 18 per minute. Thoracoabdominal with normal pattern and depth. No use of accessory muscles of respiration. JVP was normal.
Which pulse is most important in a CNS case?
Carotid pulse we should see.
Yes. What do you look for in carotid
Do you look for
pulse?
carotid bruit?
We should see. We should look for carotid bruit.
Did you look for it?
Yes, sir. Just
See, what I want to tell you is there is a pattern, set patterns. Okay, fine. Follow that. That pattern is there not to miss something. It's not that you just have to carry and write down in everything, fill it up.
yes, sir.
Whenever you mention radial delay, all those things, wonderful. You should check blood pressure in, right hand, left hand in a stroke. Patient not to miss subclinic stenosis, radial delay, radiofemoral delay. Atrial fibrillation, look for irregular rhythm. But carotid bruit, always look for carotid stenosis.
Yes, sir.
How do you look for carotid bruit, Mashuda? Just can you tell?
Yes, ma'am.
How do you look for carotid bruit? Anybody from the audience? You can unmute and tell. These are very basics. How do you look for it? With what do you look for it?
With your step only.
Yes.
Yeah.
With step, with what step?
Opposite bell.
Better
Yeah.
with the bell of the diaphragm, right? And you have to look one at a time. Don't press the carotid. Suppose if there is a fragile plaque there, it is going to get dislodged. Right? You need to be very gentle and careful when you are auscultating for bruise, especially in a stroke patient. Yeah? And don't do together both the sides. One PG examining one side, the other examining the other side. Never do. Okay.
Okay. Okay. I would like to examine CNS do CNS examination. Higher mental function. Patient is conscious and cooperative and alert. Memory, immediate, recent, and remote memory is intact. Spontaneous speech was absent. Initiation difficulties was there.
I
Word
think we should avoid commenting on memory, no, sir. At least
Yes,
the immediate
especially in
memory. Yeah.
aphasia.
Yes.
Aphasia, we don't know how to test it patient. You can just say that is why anytime whenever we present higher mental function, first is handedness. In this case, you should mention handedness, whether patient is a right-handed individual, left-handed individual, most important thing. And after that is attention. See, if patient is attentive, then only you can go ahead and check higher mental function. After attention comes the language. See, if language is affected, half of the things you cannot test. In this patient, I'm sure you cannot test more than few things. And your written there, reading is normal, reading and naming normal, repetition not tested. I don't know why not repetition tested.
That is like some words she can't repeat. Not tested.
Then you can say repetition is impaired.
Impaired.
Instead of you written repetition not tested.
You need to be cautious. You're dealing with neurologists here. Okay. And one more thing is you should also write informant from family medicine perspective. Who was the informant?
Yeah.
Was the information reliable?
Yes,
Because many a time somebody else will come with the patient who doesn't know head and tail about the patient, right? So you can ask an index relative who takes care of the patient, right? All these we need to reinforce in this. You have written right-handed individual in the first discussion, but the relevance, as sir said, is more when you actually present the higher mental function. You should say he is a right-handed individual.
Right-handed. Okay.
And at the end of this speech, Dr. Masuda, is it a dysarthria or it's a aphasia?
Dysphasia.
It is not a language dysfunction according to you. Did you check reading and writing? Tell me frankly. Did you check reading and writing? Tell me frankly.
Yes, sir. Yes, sir. She was able to write. I told her to read the other number bed. She was reading
not bed numbers, ma.
Yes,
What you should test is you should write down something like close your eyes, okay, and tell her to follow the commands without reading.
Okay, sir.
In whatever language she understands, you have to write close your eyes and tell her to understand. That's called reading comprehension.
That she is understanding, sir.
And you should tell her to write in sentences.
Oh, in sentences.
Okay.
That writing is not normal, sir.
Yeah, see, because it will tell us whether it's a language dysfunction or it's just a articular dysfunction.
Okay, sir. She wrote her name, so I wrote like that, sir. Like
wrote her name. Okay.
She was reading the opposite.
No, that is not sufficient.
It was not. I was.
See, that is not sufficient. In any language, in any language, six things are. See, in any language assessment, six things are more important. Six things. One is spontaneous speech. Second thing is comprehension. You have to assess comprehension. In comprehension also there is 3 steps command. First step is simple thing like raise your right hand, show me your tongue, close your eyes. That is 1 step command. Second thing is 2-step command. Like lift your right hand and show me your tongue. Or lift your right hand and touch your left ear. Okay. And 3-step command is like take a piece of paper from me, fold it into 2 parts and keep it in your pocket.
Okay, sir.
If 3-step command is very good, then comprehension is normal.
Okay.
Otherwise, you should say comprehension is also impaired.
Impaired. Okay, sir.
Then third thing is repetition,
Okay, sir.
and next comes reading, writing, 5, and last thing is naming.
Okay.
All these steps are important because localization is different in each is affected. Okay.
Okay, sir.
Okay. Next class we will discuss only about aphasia. It is more
Yes. I was about to
important.
say, I think
Yeah.
dysarthria, aphasia, dysphasia, language assessment itself is a
Yes, ma'am.
class. Similarly,
Class.
cranial nerve examination itself is a
Class.
including
Correct.
the fascia. Yeah.
Correct. Correct. Please continue, ma. We
Okay,
are
sir.
almost reaching time.
Okay, sir. Coming to cranial nerve examination, first cranial nerve, olfactory nerve was right and left normal smell sensation. Second cranial nerve, visual acuity normal at 6 meter, visual field normal by confrontation, color vision normal, fundoscopy normal, sir.
Was she post cataract surgery or something? Brilliant. At 83-year-old, you have a 6 vision. Yeah.
No.
Oh.
That's what madam is telling. You should not just write down everything.
Yes, sir. Actually,
You can write patient can count the fingers at the bed and rather than writing 6 by 6.
Yeah, as sir said, that's a very safe way, Nobody will penalize you for it.
Okay.
Definitely, eye examination is a must. Yeah.
Okay. 3, 4, 6 cranial nerve examination. Ocular movements left and right was normal. Ptosis and lid retraction was not there. Squint double vision nystagmus was not there. Pupil size, shape and regularity reflex normal. Light reflex direct and indirect come in normal. Fifth, trigeminal nerve, sensory superficial skin sensation over the whole face was done. Then normal over right and left. Corneal conjunctival reflex and jaw jerk was normal. Muscles of mastication was also normal. Seventh nerve, facial nerve, right and left. Wrinkling of forehead was present over both sides. Closure of eye was normal. Nasolabial fold was diminished over the right side, left side, sir. Deviation of deviation of angle of mouth is towards left. Blowing of cheek was unable to reduce it.
So is it a UMN or LMN facial weakness?
UMN type of facial palsy, sir.
Okay, good. Continue next month. You just mentioned only abnormal findings now.
Okay, sir. Rest of the patient was normal, sir.
Normal. Okay. Okay, good. Next.
8th, 9th. This all
in elderly people always look for swallowing difficulty.
Yes,
okay.
Movements, everything.
Most important thing.
And also hearing issues. At 83 years, you can't say hearing normal. Okay.
Yeah.
You need to be cautious. Use your,
cautious.
Consciously use your common sense. Really, whether it happens. Just keep this in mind. Okay.
Better not to mention only if you're not checked, rather than telling it is normal.
She was hearing properly, sir. Okay, sir.
No, what madam meant is you have to look Rinne's test
sensory
and
test.
Weber's test and
Sensory
all those
neural,
things.
some impairment definitely will be there.
Watch ticks test like that we can write, ma'am. I was.
Yeah, you can write that. You can write that. Simple Rinne's test, local, air condition better than bore conduction. Weber's test, there's no localization to one side. So that means air condition is better than bore conduction. That's enough.
Okay.
Okay.
9th nerve also nothing abnormality noted.
Okay, ma'am.
10th, 11th and 12th also normal, sir. Coming to motor system examination, no evident atrophy was noted over right and left bilaterally.
Okay.
Tone also in upper limb, both in flexor and extensor, tone was increased. Upper limb and lower limb, both sides it was increased only, sir.
Okay.
And then power in upper limb and lower limb, sir. Flexion.
See, basically, what we see now in a patient is acute stroke. Within few days, we don't see so much of increased tone. Usually it is over a period of few days to weeks, they will develop increased tone. Because if power of 3/5 and 0/5, usually tone will be
Less.
normal or hypo only. Okay. Because unfortunately we don't have a bedside examination to see whether to correct or disprove your point. But as my experience, I'm telling you.
Okay, sir. Okay, sir.
Always don't imagine that patient with hemiplegia will be having hypertonia.
Yes, sir.
Over a period of time,
Okay,
not
sir.
all hemiplegia will have hypertonia. Initially, they will have a low tone. Over a period of time, they will develop hypertonia.
Okay, sir.
Okay. Okay.
Maybe my examination findings will the way I done will be.
You go and cross check it, Amma. That's it. What I
Okay.
meant is go and cross check it once again.
Okay, sir. Okay, sir.
And keep
Okay.
examining normal individuals also. You will have
Perfect.
a feel, right? Then
Perfect.
only you try to see the abnormal, right?
Okay, sir. Okay,
Keep,
ma'am.
many a times I don't see bedside clinics happening in many hospitals. You have to just take a patient, develop a rapport, just do one CNS examination in one patient, CVS in another. That's how we
Perfect.
learn. Okay, go on.
Power in upper limb, it was a grade 3/5 in right side. In at flexion, extension, abduction, internal protection, everything was a 3 was getting up. Then at elbow joint also it was 3/5 only. But movement at wrist it was 2/5, 2/5, sir. Right sided,
Okay.
left sided everything was 5/5 only, sir.
Okay.
Lower limb at hip joint and knee movements it was 3/5. Angle also 3/5. So also I got 3/5 only. But in
Okay.
left side everything was 5/5, sir.
Normal. Okay.
Normal, sir.
Okay.
Superficial reflexes, corneal, conjunctival, abdominal reflex, everything was present on right side. But plantar was extensor in right side, sir.
Okay.
Left side it was flexor response.
See, as much as possible, try to avoid doing corneal reflex in a normal, when it is not required. Because sometimes we may give, keratitis
Infection or may
Okay.
injure it.
Where
Where do you
until
think you
unless,
should do corneal reflex?
yeah,
Then
which nerve will be Madam, question is which nerve will
Get affected and which circumstance you should do a corneal reflex. It is one of the mandatory assessments. Somebody is deeply comatose, or you're thinking of brainstem, brain dead
organ
patients,
donation.
organ donation, you have to check for corneal reflex. But
Correct.
always use a sterile cotton bud.
Sterile cotton, not to, we should be very careful. See, what I want to tell is, don't do corneal reflex in all patients, and it's very painful. Only when you want to test fifth cranial nerve sensation, then only you should do it. Only in selected patients. Don't do it in a stroke patient, especially elderly lady. Okay.
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 Reflexes, deep tendon reflexes, bicep, triceps, supinator, knee jack was there. It was 3+.
Yeah, below written absent abdominal reflex, exaggerated deep reflex, Babinski saying positive on the right side. Better to mention brisk reflexes, brisk deep reflex rather than exaggerated.
Yeah.
Okay, sir. Okay.
Exaggerated with clonus.
Okay. That will become 4, sir.
Yeah.
Okay.
Yes.
Okay, sir.
Okay, sure.
Sensory system was intact, sir.
Intact. Okay, next.
Cerebellar, whichever I test, it was absent only, sir.
No, patient has a weakness. You cannot test until unless patient is above 4/5 power. You cannot test all these things. Dysmetria, dysdyskinesia, intention tremors, all those things. So be very careful.
So unless the
Okay.
power is 4, don't do assessment for cerebellar dysfunction.
Cerebellar.
Okay.
Fine. Cerebellar. Patient has weakness, no, ma'am.
Yes,
Patient has hemiplegia. How can you test? How can you
Cerebellar
test
function
rebound
test.
phenomena, intentional tremors, fast pointing, and all those things? Patient barely can lift the hand. Okay,
If the
should be careful. Should be
okay,
careful. Either you can say left side it was normal, right side I did not test, or
sir.
you can just say there is no nystagmus only and speech. There is no scan speech and stop it there.
Okay, sir. Left side or right side?
Okay. Oh, you written there in the down. No
Yes.
cerebellar dysfunction on the left side. Okay, okay, sure.
Signs
Okay,
of
continue.
meningeal examination of skull and spine normal. Auscultation over neck over the skull. No bruit over the skull. No carotid bruit. Patient was
Okay, good. You written here.
then stands and gait. Patient was unable to
Hands and
stand.
gait. Yes.
Okay.
Good. You have not mentioned gait normal.
Other,
Continue, continue.
other system examination. Serious
Anything
infection.
positive only if you can,
No, sir.
highlight because of lack of time.
Okay,
Nothing, no? Yeah, lack of time.
Every system finds normal element. Okay.
Okay, I just, because treatment is also important, you should not stop
Yes.
at that, I just finish it up. How would you manage this patient? How do you treat? If patient comes in window period, how do you manage? If patient comes out of window period, how do you manage?
If patient
Yeah.
comes
It's
within
not 3 to
golden
4
hour,
hours, it is always 4.5 hours. 4.5 hours. Earlier the better. You should not wait till 4.5 hours. That is the first and foremost thing. And another important thing, see, before alteplase was there, where you have to give 10% bolus, IV bolus, and then remaining 90% over 1 hour.
Yes, sir.
Now there is tenecteplase. That is also approved.
That is
BCG
single.
approved. That is 0.2 mg per kg, 0.2 mg to 0.25 mg per kg. One straight bolus only you can give. That is easier to give. You don't have to give infusion. Okay.
It
And
is available everywhere, sir?
It's available everywhere. Okay. And now government of Karnataka will also make it available everywhere in district hospitals also. Okay. So you should all start using tenecteplase. Easier to use it. And always remember, always take written informed consent from the patient relatives about risk of hemorrhage about 6%.
6%.
Okay. 6%. Okay. It's always better to inform and take a consent. And I was telling about that wake up stroke. See, sometimes we don't know when exactly the stroke happened, when patient went to bed or when patient got up. So what we do is CT scan we do. If CT scan is absolutely normal, then it is a stroke might have happened within 3 hours. If patient do a CT scan already shows the signs of infarction. That is already CT scan is showing black hypodensities. Then it is more than 6 hours. Okay. Or another best thing is MRI. You do an MRI. There are different sequences will be there in MRI, like flare, diffusion. Diffusion is showing a bigger infarct, whereas flare is normal, or flare is hardly showing any changes. We call it as flare diffusion mismatch. That is a sign that it's a sign that it's a salvageable tissue. That core is very small. It's a salvageable penumbra is bigger. So whenever there is a flare diffusion mismatch, you can still go ahead and thrombolize in a wake up stroke. Okay, that is one acute management. How do you prevent further stroke?
Further stroke by dual antiplatelet therapy, sir? Or
correct.
statin?
How long do you give dual antiplatelet?
This is very important. Do you give it lifelong?
Do you give lifelong dual antiplatelet? And this patient is 85-year-old lady.
Yes.
She'll come back with a subdural hemorrhage.
Hemorrhagic.
3 to 6
See, basically
months.
what? No. Don't say 3 6. If the patient has a lacunar stroke, lacunar is a small stroke, less than 15 millimeter. If the patient has a lacunar stroke, you will give double antiplatelet for 3 weeks only.
3 weeks.
After 3 weeks, you will continue only single antiplatelet. That is usually ecosprin, aspirin. Okay, ma? If patient has a large vessel stroke,
Okay.
like a MCF infarct or it's a carotid artery stenosis, then you will give double antiplatelet for 3 months.
Okay. 3
After
months.
3 months,
Okay.
after 3 months, you continue single antiplatelet.
Okay, sir.
Okay, and if patient
Yes.
has a cardioembolic stroke or a patient has a atrial fibrillation or a recurrent embolic stroke, even after double antiplatelet, patient should be started on anticoagulation.
5 months.
Okay,
Yes, sir.
see,
And
this is
just 1 or 2 words about pregnant lady coming to stroke. No, it is a huge challenge, no, sir. Pregnant lady
correct.
coming
Absolutely,
with
madam.
stroke, especially a massive
And
strokes.
and whether to thrombolize or not will become another major concern.
That time
So
you
best
please
is,
take experts' opinion. Put neurologist into picture. Don't handle alone.
you should always be individual case to case base. You cannot generalize in a pregnant lady. Always better to do angiogram. If there is large vessel occlusion, mechanical thrombectomy is the safest option in a pregnant lady. Because chance of bleeding from placenta will be very high in a case if you thrombolize. So
Yes.
that is a relative contraindication.
And a bit about some stroke mimics which come like acute post-delivery, they come with cortical venous thrombosis. Can you just a bit, because stroke mimics also we should be able to differentiate from actual stroke patients.
Absolutely. CVT, because CVT treatment is anticoagulation, not antiplatelets. Somebody has messaged single
And
platelet antiplatelet for how long? It should be lifelong.
yeah, they want you to repeat the treatment part of dual antiplatelet therapy, sir. If you can just, you were talking about lacunar infarcts, large infarcts. Can you please
If it's a
repeat?
lacunar if it's a lacunar infarct, we'll give double antiplatelet for 3 weeks. Okay,
Yes,
that
sir.
is aspirin plus clopidogrel. After 3 weeks, usually we'll stop clopidogrel and continue only aspirin. If it is a large vessel occlusion, like MCI infarct or ACI infarct, it's in a vascular territory infarct, or PCA or posterior circulation stroke, then we'll continue double antiplatelet for 3 months. After 3 months, usually we'll stop clopidogrel and continue aspirin. And single antiplatelet should be continued for lifelong, as much as possible, until there is any contraindication. And
This is
if
very
patient has a
important, PGs. You have to remember this. Don't continue aspirin and clopidogrel lifelong. It has lot of side effects and it is not recommended. Yeah.
Correct. And patient has a cardioembolic stroke, then it is better to continue anticoagulation. Like now there are newer oral
Anticoagulants.
anticoagulants. Okay, so NOACs can be continued, and usually we'll continue with single aspirin if there is any associated atherosclerotic risk factor 75 mg. Okay.
Yes, along with novel anticoagulants. No, sir?
Yes,
That's
yes,
what
ma'am.
you.
Yes, ma'am. Correct.
And I personally, which one do you prefer? Is it dabigatran or rivaroxaban or apixaban? Apixaban is.
Ma'am, I usually go for if there is a CKD, then apixaban. Otherwise, dabigatran. Apixaban. Second option is dabigatran because we have a reversal agent. So if at all something happen, we can always go for reversal agent.
Okay.
Okay.
And as a family physician, what other aspects would you want to consider, Mashuba, in this particular patient?
Physiotherapy and rehabilitation.
Yes. What rehabilitations would you think of? Apart from physiotherapy. See, the nutritional rehabilitation and the mental health of the patient, and also the caregivers, the financial burden, the social implications. No, you should. And many of them, I have heard people going to some Batralli and putting some Puttur cut and all these things going on. So it is our duty to educate them that they may not be of much use. Okay, and wiser to follow this therapy, especially nutritional rehabilitation, right? It starts from oral hygiene. I'm sorry to say this, many of them, they don't give importance to this because they have a facial palsy, they don't brush, they don't take bath, they develop bed sores. So you need to focus on all these areas and also give them small work. Whatever, whenever they are capable of doing minimal work, please give them something, a part of, some small things they can get involved in home related activities so that they are not left, unattended, and also they don't have some mental issues like depression. And also you have to
No, that's the
educate the
most important thing,
attenders
ma'am.
how to monitor BP, how to monitor sugar, write them the chart. And as family physicians, please follow up. You can get connected to them once in 15 days. These are simple measures which will add a lot of value in long-term care of the patients. Okay, you need to pay importance to this. Anything else?
As Madam
Anybody has
mentioned,
any
mental health is the
questions?
most important thing post-stroke depression.
Yes, sir.
Ma'am, post-stroke depression is another important thing which we may not cater into. We have lost one of our my friend who was a
Yeah, I think it's
community
a
medicine
huge,
doctor.
vast topic, sir, and you have done it so well
I know.
that probably from Karnataka chapter, I think we will have a second session after discussing with you. Nishant is here. I'm sure he
Sure,
will
sir.
also agree with me. Yeah, so
Yeah,
that,
we'll plan
we have a
another session.
continued education and a total, understanding of dealing with stroke patient. As sir said,
Correct.
dysarthria, dysphagia is another topic which we all have to understand. And nutritional rehabilitation in such patients, how do we educate practically, not just putting a Riles tube and sending them when they have a lot of difficulties in swallowing, and other aspects like how sir said, the depression component of it. I think we will have
Correct.
another session with your permission, depending on your
Sure.
availability. We can continue the
Sure, ma'am.
same case, right? Thank you. It was
Sure.
a very interesting session. Sir did not look at time, but we have to, wind up.
Yeah, please, madam. Yeah, sorry. Yeah,
No,
I'm thankful and grateful for this opportunity. And
I
again,
think
once
we need
again,
more
thank you.
participants. It's such a wonderful, fantastic session, so enlightening, so stroke simplified by Dr. Mahendra Jain sir. So everyone is messaging that it was a fantastic session and they want future sessions as well. So a lot to learn from you. So we will keep in touch, sir. I think
Thank you. Thank you.
we should all.
Sure, madam.
I
Thank you.
think
Thank you
next
so much.
time all of you should write a protocol. How do you deal with stroke? Try to today only sit and write what are the discussion points sir has reinforced in the history, in the examination, and also from treatment perspective. Do it today, otherwise you will never do it. So that you write down, jot down some key points, and you are much better for the next session related to CNS. Yeah, over to Nisha.
Okay.
Thank you very much, Mahendra sir and Soumya ma'am, for moderating this session. I'm sure the PGs found it to be very helpful and useful. Thank you very much, sir. And I thank Dr.
Yeah,
Mashuda Banu
welcome.
for Dr. Mashuda Banu for coming forward and presenting the case. It was a nice case presentation. Thank you very much.
Definitely, Masuda, you've done very well compared to other, contemporaries, and you can still do better. Okay, it was a good presentation. I'm sure
All the
Mahendra
best.
sir will also agree. Yeah.
Yeah,
Thank
all
you.
the best. It was a
Thank
good
you, sir.
presentation. Yeah, all the
Thank
Sure.
you. Thank you.
And next time you have to
Okay.
present how you manage this patient for some short time. Never stop seeing this patient. Keep in touch. Yeah.
Okay, okay, ma'am. Okay.
Okay.
Thank you.
Sure.
Okay,
Sure.
sir. Thank you so much, sir.
Thank you.
Good day, sir. We'll get
Good
connected
night. Good
tomorrow.
night. Good night.
Good night, sir.
Good night.
Sure.
Thank
Good
you,
night.
Thank
everyone.
you.
Thank you.
Thanks. Please.